Good day everyone, we are Block 8 and today we will be presenting a case study on the topic of Cytomegalovirus or CMV. Key points of the case study. The patient information, she is a 59-year-old female. She underwent a cardiac transplant 6 months earlier for idiopathic cardiomyopathy. She is seropositive for cytomegalovirus at the time of transplant and seronegative for HIV, hepatitis B, and hepatitis C. The heart donor was CMV seropositive and negative for HIV, hepatitis B, and hepatitis C. Now, for clinical history, generally well post-transplant with 2 episodes of acute rejection requiring increased immunosuppressive medication. Developed symptoms 1 week before admission such as malaise, fatigue, low-grade fever, mild dyspnea on exertion. Now, for the physical examination findings, elevated temperature 38.3 degrees Celsius, Cushingoid body habitus due to steroids, and fine bibasilar rails on lung examination. Now, for the diagnostic tests and procedures, Guaya positive stool specimen, her laboratory results were hematocrit of 24%, she has leukopenia, and a normal platelet count. Transfusion with 3 units of blood, upper gastrointestinal endoscopy revealed nodular gastric erosions. Biopsies and brushings were taken and submitted for pathology and microbiology evaluation. Her chest radiograph showed diffuse infiltrates, bronchoscopy performed, and transbronchial biopsy and bronchoalveolar lavage specimens sent for examination and cultures, and gram stains were negative. Now for the diagnosis, Papa-Nicolau stains of gastric lesion, brushings, and lung tissue revealed the cause of her infection, most likely CMV. Molecular testing of her blood detected a high viral load of CMV. Next is a figure showing the Papa-Nicolau staining of gastric brushing, and now we move on to the guide questions.
As for the first question, what was the most likely etiology or cause of the patient's infection or how she became infected, this was due to either the organ transplant she received from the donor or the blood transfusion episodes due to low hematocrit and WBC levels. The heart donor was tested to be CMV seropositive and was later manifested in the receiving patient that she too became seropositive for this virus. This viral infection is the reason why she had gastric and pneumonic inflammations and caused the patient to have several other complications. To avoid this case from happening again, organ transplant patients must be tested for CMV at least twice before the transplant or operation, since CMV is one of the most significant viral infections that can be acquired for solid organ transplant or SOT recipients, providing a series of other life-threatening complications or diseases.
For the next question, what is the typical clinical presentation of this organism in patients such as this woman who have received solid organ transplants? Cytomegalovirus or CMV infections are commonly observed after solid organ transplants with a prevalence ranging between 8 to 50% depending on various factors including the transplanted organ and the CMV serostatus of the donor and recipient. CMV disease can manifest with a broad spectrum of clinical presentations spanning from mild and manageable symptoms to life-threatening conditions, making it a challenging and variable post-transplant complication. Severe CMV disease is more frequently observed in recipients who are seronegative for CMV, those who have not been exposed previously but receive organs from seropositive donors, as their immune system are less prepared to combat the virus. Common initial symptoms of CMV disease include fever and a decrease in the number of white blood cells or neutropenia, which can often be nonspecific and challenging to diagnose. CMV infection can lead to a range of clinical manifestations, including swelling of lymph nodes or lymphadenopathy, liver inflammation such as hepatitis, reduced platelet count or thrombocytopenia, as well as diverse gastrointestinal and pulmonary symptoms. In rare instances, severe CMV disease can result in meningitis, an inflammation of the membranes surrounding the brain and spinal cord, which can be a life-threatening condition. Moving on to the next slide, CMV has an inclination for the transplanted organ, causing organ-specific issues. For example, in liver transplant recipients, it can lead to hepatitis, while in heart-lung transplant recipients, it may result in pneumonitis. CMV infection can have indirect effects, including harm to the transplanted organ or allograft injury, increased risk of organ rejection, susceptibility to other infections, and potential development of Epstein-Barr virus-associated post-transplantation lymphoproliferative disorder, a condition characterized by the uncontrolled growth of certain immune cells in response to Epstein-Barr virus infection.
The clinical case of the 59-year-old female patient critically implies a cytomegalovirus infection. Cytomegalovirus, or CMV, is an enveloped, double-stranded DNA virus and is the most common infectious agent complicating transplantation. It is also the fifth viral agent among all the 8 human herpes viruses. This virus was the cause of the patient's gastritis and pneumonitis. Without antiviral prophylaxis, CMV infections usually occur 1 to 3 months post-transplant. CMV, like other herpes viruses, causes lifelong latent infection. The source of the patient's CMV infection could also have been either the CMV positive organ or the blood transfusions she received. CMV infections are common in immunocompromised individuals, but clinical disease is rare. The immunosuppression of cell-mediated immunity necessary in transplantation greatly increases the likelihood of developing clinical disease with CMV, whether through reactivation of the patient's latent virus or viral superinfection from the transplanted organ or blood products. Moreover, it is also important to take note that the characteristic of Owl's eye cell containing large internuclear 18 inclusions seen in the Papinicolau staining of gastric brushing of the patient is one of the clinical identifications of cytomegalovirus.
Moving on, what makes CMV's morphology unique? Cytomegalovirus possesses a similar morphology typical of the herpes group. An icosahedral capsid composed of 162 elongated capsomeres, an inner core and envelope containing glycoproteins for attachment. Its DNA genome is composed of a short and long unique gene region. The virus can exist in 4 isomeric forms due to its internal and terminal repeats. Infection of CMV may lead to defective envelope particles or dense bodies. These are non-infectious structures that are antigenic. They contain spherical particles surrounded by a membrane similar to an envelope, usually 300 nanometers in diameter. These bodies or particles contain little DNA or absence of it. Uranyl acetate stains of CMV had numerous larger bodies containing 1 or more particles and showed incomplete or absence of nucleic acid staining in the core area. Unique to only CMV are the owl's eye intranuclear inclusions in the infected cells, shown in the lower right picture. These cells depict an enlarged nucleus and cytoplasm, with distinct or demarcated nuclear membranes and condensed chromatin surrounded by a halo. To sum it up, CMV's virion resembles herpes virus morphology, and infection can lead to production of dense bodies. CMV-infected cells show an owl's eye intranuclear inclusions, which makes it distinguishable from other herpes groups.
On to the next section, we'll be discussing on what is the epidemiological distribution of the disease, specifically your cytomegalovirus, worldwide, nationally, and locally. First off is the worldwide distribution, wherein according to a study conducted by Zuhair and his colleagues in 2019, there is an estimated seroprevalence of 83% found in the general population due to CMV's ubiquitous characteristics. In addition, Cannon and his colleagues in 2010 stated that CMV seroprevalence tended to be highest in South America, Africa, and Asia, and lowest in countries that are present in your Western Europe and North America. With the viral characteristic of CMV being able to infect people of all ages, 50% of the adults that are infected are at age 40, according to the CDC and WHO. While for the congenital CMV rates, they have a range of about 0.2% to 3% in live birth as stated in the study by PASS done in 2012. Aside from your congenital infection, a study by Shvetkovich on 2007 states that neonatal infection is also observed when the primary infection occurs during pregnancy, and this has a transmission rate of 30% to 50%. Lastly, for healthy patients, CMV has a mortality rate that is lesser than 1%, since infection is generally asymptomatic and it can only cause severe disease in immunocompromised patients, transplant, and transfusion recipients. Moving on to the distribution of CMV nationally, specifically in the Philippines. A descriptive study was done by AGPES, and they later found out that out of 70 cases of your organ transplantation in Baguio City General Hospital, only 41 or 59% were reactive to the CMV IgG. Moreover, AGPES also found out that the CMV incidence rates were higher among older age groups and groups that have low socioeconomic status. Unfortunately, though, for the local distribution, there is insufficient data on the epidemiological distribution of your CNV in the Visayas region.
The next is the pathophysiology of cytomegalovirus or CMV. Now, once you get transmitted with the virus, it does not cause a lytic infection. Rather, it causes latent and persistent infection or a lysogenic infection, meaning that the infected cells, specifically lymphocytes, will not lyse. Instead, they are used to transport to the other parts of the body and infect specific tissues. Actually, there are three phases of CMV infection. You have the primary, secondary, and tertiary phases. For the primary infection, it is when the virus was first transmitted or introduced to the susceptible host, and the host hasn't still established any defenses against the virus. And then it undergoes the secondary or the latent phase, and then lastly, we have the tertiary phase, wherein the virus gets reactivated. So in the case of the patient, her CMV infection was already in the tertiary phase upon the transplantation of the heart. Diba she took immunosuppressive agents, corticosteroids, steroids to be specific, to be able to suppress her immune system and accept the newly transplanted heart. Now she isn't aware that the donor of the heart is also CMV positive, so there was a super infection. Now, as mentioned a while ago, it uses lymphocytes and other leukocytes to be able to transport across the body and infect different tissues. And so it is an expert at immune evasion. It alters the function of lymphocytes and leukocytes. CMV can be transmitted through several modes of transmission. One is through contact with blood, with an infected blood. Second is when you have a sexual intercourse with an infected individual. Third is when you get in contact with other body fluids that are positive with CMV. Next is when you get transplanted with CMV positive organs. And then lastly, through vertical transmission, wherein the mother is infected with CMV and she passes it to her baby. Now, in the case of the patient, she was already infected with CMV prior to her heart transplantation, and we thought that maybe she got it when she got transfused with blood. And then she got a super infection with the same virus through heart transplantation. So one unique clinical manifestation of a CMV infected tissue is that it has an inclusion body that looks like an owl's eye. When a healthy individual gets infected with CMV, he or she doesn't usually exhibit symptoms, or if there are symptoms, it is usually mild flu-like symptoms only. However, among immunocompromised individuals, like the patient in this case, they develop a syndrome of infectious mononucleosis. They also develop hepatitis with increased immune transferases, which is usually subclinical without the case of jaundice. And then they also develop atypical lymphocytosis, which can be explained in a previous slide. It can be somehow similar to Epstein-Barr virus or EBV, which are both herpes viruses, but CMV usually lacks pharyngitis and has less intense lymphocytosis. It can also be differed through clinical tests. Symptomatic CMV disease can affect almost every organ of the body. It can cause fever of unknown origin, pneumonia, hepatitis, encephalitis, myelitis, colitis, uveitis, and retinitis, which is the most common manifestation of CMV infection in patients with HIV, and neuropathy.
Now, this juncture, what laboratory tests are appropriate for the identification and confirmation of the agent of infection, which is the cytomegalovirus? CMV-associated diseases are typically diagnosed through the direct examination of the infected tissue, which reveals the characteristic features of owl's eye cells. However, you can make use also of CMV-specific in situ hybridization on tissue to help diagnose CMV-related diseases. Other diagnostic methods includes shell vial cultures, direct antigenemia, and nucleic acid amplification test, or NAATS for short. First, let us go with shell vial cultures. While conventional cell cultures were once used for CMV detection, they are much slower and less sensitive compared to modern techniques, and one of them is shell vial cultures, which is a faster alternative that involves growing fibroblast cells and using fluorescent monoclonal antibodies to detect CMV early antigens, and typically it provides result within 1 to 2 days. Second, we have direct antigenemia. In the context of detecting CMV in peripheral blood, direct antigenemia was historically the standard one, especially for post-transplant patients. However, it is labor-intensive and has limitations regarding patients with low neutrophil counts, and it led to the replacement by the third and the most appropriate test for CMV, which is the nucleic acid amplification test, or NAATS for short, and it has quantitative real-time PCR being the prevalent method for diagnosing CMV diseases. While specific guidelines for therapeutic intervention levels based on the viral load are not firmly established, data suggests that viral load approximately 2,000 copies per ml may be significant already, and an international standard for CMV viral load reporting is emerging, which enables the determination of clinically relevant quantitative thresholds in the future. However, it is important to take note that using nucleic acid amplification tests for CMV detection has its own downside, and this includes inability to differentiate latent from actively replicating virus. Therefore, the need for clinically relevant viral thresholds to guide treatment decisions remains critical aspect for cytomegalovirus.
The best prevention for CMV transmission due to organ transplant is to receive organ from a seronegative donor. However, this approach is most often neglected due to the high rate of CMV seropositive donors. Hence, alternate interventions such as prophylactic therapy and preemptive therapy are employed. In prophylactic therapy, all transplant patients at risk for CMV disease are treated with a prophylactic regimen for 3 to 6 months. Preferred prophylactic regimen depends on the type of transplant, but it usually consists of anti-CMV agents such as ganciclovir with or without CMV immunoglobulin. The other approach is to use preemptive therapy. It involves screening patients for the presence of CMV in peripheral blood with a highly sensitive technique such as antigen testing or quantitative PCR. Patients would be treated with anti-CMV agents with or without CMV immunoglobulin to prevent them from developing clinical disease. Unlike prophylactic therapy, which is used on all at-risk patients, preemptive therapy is used only on those patients with evidence of CMV in their bloodstream. 3 main drugs are currently available for the treatment of CMV infections. These are your ganciclovir and its oral version, valganciclovir, foscarnet, and cidofovir. Valganciclovir is a prodrug of ganciclovir that is converted to the parent compound by intestinal and hepatic esterases. All of the drugs inhibit viral replication by inhibiting the activity of CMV DNA polymerase. Ganciclovir must be phosphorylated 3 times to be active, while cidofovir requires 2 phosphorylation steps. Both are performed by cellular enzymes. Phosphorylated forms of ganciclovir and cidofovir slow and then stop CMV DNA chain elongation by competing with DGTP.